Hello, my name is Dr. Alsohaibani. I'm consultant gastroenterologist at King Faisal Specialist Hospital and Research Center, associate professor at Al Faisal University. Today I'm going to talk about management of upper GI bleeding, and the objectives are to discuss the following: the epidemiology and risk factors for upper GI bleeding, clinical presentation, and how to differentiate between upper versus lower GI bleeding, risk assessment, stratification, acute management of upper GI bleeding, and the role of the endoscopic therapy. So I'm going to take you in a journey through all of these objectives in the next 30 to 40 minutes. Let's start with some definitions of the following names or nomenclature. Hematemesis, what does it mean? It is a vomiting of red blood, and sometimes we call it coffee ground emesis if it is really an old blood or digested blood. Melena is a passage of tarry black stool, which is a foul smelling usually, and usually it requires around minimum of 50 ml of blood to render the stool melanous. Hemotocrit is a passage of fresh red blood per rectum. Let's go at the beginning through some epidemiology. Unfortunately, we don't have data from Saudi Arabia. However, we have data from elsewhere in the world. Let's start with the data from United States. It is a common medical problem. There is up to 500,000 admissions per year in the United States with upper GI bleeding. And upper GI bleeding incidence is around 1 in 1,000 persons. And upper GI bleeding usually stop spontaneously in 50 to 80% of those presenting with upper GI bleeding, and the majority of those will receive blood transfusion. 2 to 3% will require urgent surgery to stop the bleeding, and the mortality rate of the upper GI bleeding usually ranging between 4 to 5%. However, in hospital upper GI bleeding, the mortality rate is higher in the rate of between 10 to 20%. We have a Canadian data. 15,000 admission per year. Average long of stay in the hospital is around 4.5 days, and average cost per case is 2,700 Canadian dollar, and most of the studies there show the mortality rate is below 5%. How to classify upper GI bleeding? We can classify upper GI bleeding into either portal hypertension or non-portal hypertension. The most common cause of upper GI bleeding is non-portal hypertension, and most of these cases due to peptic ulcer disease that represent 50% of the causes of upper GI bleeding. Other causes of upper GI bleeding, which is non-portal hypertension, are listed here, including the erosions either in the stomach, in the duodenum, malarious tear, erosive esophagitis, malignancies, either esophageal, small bowel, or gastric, and de la voie lesion and arteriovenous malformation. The 20% causes of upper GI bleeding, which is due to portal hypertension, are listed here, and the most common cause is esophageal varices, and less commonly gastric varices and portal hypertensive gastropathy, and sometimes even varices can occur any part in the small bowel and large bowel. This diagram will show you the causes of the upper GI bleeding as listed before. As you can see, the causes, it can be listed to variceal versus non-variceal, or portal hypertension versus non-portal hypertension. As you can see, peptic ulcer disease represents between like 35 to 50%, and most common cause for peptic ulcer disease either Helicobacter pylori or ingestion of non-steroidal anti-inflammatory agents, including the aspirin. Other causes are listed here. So because of the most common cause of the upper GI bleeding is peptic ulcer disease, let's go through the risk factor for peptic ulcer disease. And the most common risk factor for peptic ulcer disease is Helicobacter pylori. And the risk ratio is 1.8. Taking aspirin also is a risk factor and will have a relative risk is 2.3. If the patient is taking a small dose, which is 75 milligram. However, the risk will be higher to 3.9 if the patient is taking a higher dose of aspirin, such as 300 milligram daily. Other causes, non-steroidal anti-inflammatory agents. It depends on the type of the non-steroidal anti-inflammatory agent. The safest one, we think it's most likely, is the ibuprofen, and the worst one is the ketorolac. You can see the relative risk or the risk ratio is around 4 to 5 compared with the general population. If you combine non-steroidal anti-inflammatory agents and Helicobacter pylori, the risk ratio increased to 6. Other causes and risk factors for upper GI bleeding, including what we call selective serotonin reuptake inhibitors, and will increase this risk to 3.6. And other causes of peptic ulcer disease, including like stress, ICU admissions, and Zollinger-Ellison syndrome. This graph also will represent again what I have mentioned before in the previous slide, the relative risk or what you call risk ratio of each risk factor to cause peptic ulcer disease compared with the general population. Let's switch gear now and talk about variceal bleeding, which has a different mechanism from peptic ulcer disease. And variceal bleeding, usually it is due to portal hypertension. And portal hypertension can be classified according to the site of the portal hypertension. It can be prehepatic due to, for example, portal vein thrombosis, or hepatic, which is the most common cause, due to liver cirrhosis or advanced fibrosis, or it can be post-hepatic, for example, due to Budd-Chiari syndrome and congestive heart failure. As you can see, the portal vein is a combination of the splenic vein and the superior mesenteric vein. They combine and they form portal vein. In normal liver, usually the blood flow will move smoothly through a liver parenchyma up to the hepatic veins, then from hepatic veins to the inferior vena cava, then to the heart, then to the lung and systemic circulation. However, in patients with liver cirrhosis or advanced fibrosis, the blood flow will not be as smooth as normal people. This would cause stagnation and reversal of the flow from the liver backward, and this will cause the blood to find another channel to bypass the liver to the heart. And this is what will cause the creation of the esophageal varices, gastric varices, and splenic varices. As I mentioned before, the causes of portal hypertension can be prehepatic, and the most common cause is the portal vein thrombosis, or pre-sinusoidal, and the most common cause in Saudi Arabia and in Africa is what we call bilharziasis or schistosomiasis. Sinusoidal, and this is the most common cause of portal hypertension due to liver cirrhosis, or post-sinusoidal disease like in veno-occlusive disease in those patients who receive chemotherapy for bone marrow transplantation. And the other cause is what we call Budd-Chiari syndrome, which is hepatic vein occlusion due to thrombosis. Esophageal varices present in most patients with advanced liver cirrhosis and can be the cause for bleeding with those patients up to 70%. 10% bleeding due to gastric varices or fundal varices, and 10% can be bleeding due to non-variceal due to what we call portal hypertensive gastropathy. And this is due to congested gastric mucosa due to portal hypertension. Remember, 10% of those patients who have portal hypertension, they can present with upper GI bleeding, but still due to non-portal hypertension such as peptic ulcer disease. Variceal bleeding, remember the varices present in 60% overall. However, this correlates with the severity of liver cirrhosis. For example, patients with child A liver cirrhosis, they have varices in like 10 to 15%. If the patient has child B, it will go up to like 40%. Child C, 60 or even 70%. 30% those patients will bleed within the 2 years from diagnosis of liver cirrhosis. And the variceal bleeding account up to 20% of the upper GI bleeding. The rebleeding rate is usually high, and the mortality rate in those patients in up to 40% within the first 6 weeks. When do we suspect variceal bleeding? We suspect variceal bleeding if there is a history that indicates this patient might have chronic liver disease, like history of alcoholism, history of hepatitis B, history of hepatitis C or autoimmune hepatitis. If the patient had a prior history and a prior endoscopy that did indicate this patient has esophageal varices or gastric varices or portal hypertensive gastropathy. Other thing that might indicate this patient might have portal hypertension bleed or variceal bleed is presence of stigmata of chronic liver disease on physical examination. Presence of jaundice, for example, ascites, spider nevi, uterine contraction, paramerythema, and so on. The other hint for portal hypertension, when you do the lab and you find this patient has evidence of liver derangement, hyperbilirubinemia, decrease in the platelets count, or decrease in the sodium, elevated INR and coagulation. All this indicator that this liver is deranged and this patient might have portal hypertension due to liver cirrhosis. Usually presentation of upper GI bleeding, either hematemesis, as we mentioned before, melena, or both. If it is massive, the patient might present with hematochezia, which is fresh bleeding per rectum. And this presents up to 10% of patients with upper GI bleeding. Other patients might present with symptoms of anemia, such as dizziness, lightheadedness, and syncope or pre-syncopal episodes. Patient might present with complication to the emergency room due to massive bleeding due to either hypovolemic shock, due to cardiac arrhythmia, cardiac ischemia, or aspiration pneumonia. Let's go through this case discussion. We have a 65-year-old female who presented to the emergency room with 2 episodes of vomiting blood over the past 3 hours. So what do you want to know? Now take a few seconds and write down what do you want to know in this patient if you are going to take the history if you meet the patient in the emergency room. Okay, so you would like to know the following: the bleeding, the amount, was there is a melena, was there is a hematochezia, was it fresh bleeding or it was a coffee ground emesis, any other symptoms such as abdominal pain, chest pain, shortness of breath, dizziness, syncope, loss of consciousness, retching that might suggest miliary tear, weight loss might suggest malignancy, dysphagia might suggest malignancy. What patient is taking with regard to medications, especially the anticoagulants, aspirin, non-steroidal anti-inflammatory agents, corticosteroids, selective serotonin reuptake inhibitors, and proton pump inhibitors. If the patient is taking good dose proton pump inhibitors, that make you think less likely this patient might have bleeding due to peptic ulcer disease or esophagitis. Other thing in the history should really stress on prior history of GI bleeding. Any comorbidities, either cardiac, lung, kidney, liver disease, and prior endoscopy. And is this patient has been treated for Helicobacter pylori in the past or not? Then you will proceed for physical examination, and the most important for you is to look in general for the patient, look how is he looking, the weight, the body mass index, and the vitals. Vitals are very critical. You have to look for the patient vitals: blood pressure, heart rate, respiratory rate, oxygenation, temperature, and level of consciousness. If the patient is not hypotensive, you might induce hypotension by either standing the patient up if the patient condition allows, or sitting him from supine position. This might provoke what you call postural hypotension. And this is drop in the systolic blood pressure more than 20 millimeter mercury, or diastolic more than 10 millimeter mercury, and increase in the heart rate for minimum of 10 beats per minute. Examine the patient mouth for telangiectasia. Look for stigmatic chronic liver disease. If there is any lymphadenopathy, examine the abdomen. Look for stigmatic chronic liver disease in the abdomen. Is there any ascites? Is there any capitomedosa, splenomegaly? And it is compulsory to examine the rectum. You have to do a PR examination for this patient to document is there is a fresh blood, is there is a melena, or you might detect a rectal mass. With regard to the NG tube insertion, it is a controversial, and we'll discuss it in the next few slides. With regard to the postural hypotension and shock and maintaining the normal pressure in patients with GI bleeding, it depends basically on the amount of the blood loss. If the patient is losing less than 10 of the intravascular volume, less than 10%, usually the hemodynamics will be maintained and the blood pressure and pulse will be normal. If the patient loses between 10% to 20%, this will induce what we call postural hypotension, and this is a moderate bleeding. If the patient loses more than 20%, this will suggest this patient lost very significant amount of blood, and the patient will present with persistent hypotension and tachycardia. Now, let's discuss about how to differentiate is this is an upper or lower GI bleeding. Basically, you'll go with the symptoms. If the patient presents with fresh blood hematemesis, this is obviously upper GI bleeding. However, patient might present with lower GI bleeding or hematochezia, and you are really questioning, could this be a massive upper GI bleeding or lower GI bleeding? How can I differentiate between the two? You can go back to the history and ask the patient if the patient has, for example, chronic liver disease, history of ulcer in the past, history of endoscopy, showed non-healing ulcer in the past. This might give you a hint. This patient might have most likely upper GI bleeding. Look to the hemodynamics. If the patient is hypotensive, most likely the source of bleeding is upper GI bleeding rather than lower GI bleeding. Lower GI bleeding rarely causes very significant hypotension. Other trick is to look to the lab and look for the what you call urea to the creatinine ratio. If the urea to the creatinine ratio more than 30 or 36 in the text box in milligram per deciliter, this suggests most likely this bleeding is coming from the upper GI source rather than lower GI source. Other hint, if you are really confused, you don't know what's going on, you can consider insertion of the NG tube and suction and aspirate, and if there is a fresh blood, this might suggest this patient has upper GI bleeding. However, it has a falsely negative, sometimes the bleeding from the duodenum, it will give you a negative NG tube aspirate, and sometimes will give you false positive because you might induce injury to the gastric mucosa or esophageal mucosa and it will be positive, and you might think this is an upper GI bleeding and the case is not upper GI bleeding. So still there's a debate whether we have to put an NG tube or not, but most of the cases they don't require insertion of the NG tube. So how we do our diagnostic evaluations in patients presenting with upper GI bleeding? First of all, make sure you stabilize the patient and you send the blood work including the following: CBC, coagulation profile, liver function test, renal profile, and using what you call urea creatinine ratio if you can. Very important to type and screen and hold at least 2 units of blood for the patient. And if the patient had a cardiac history, it's very, very important to do an ECG and serial cardiac enzymes for those patients. Remember, if the patient presented acutely with upper GI bleeding, the hemoglobin and hematocrit may be falsely normal in those patients because there is no equilibrium or no shift of the plasma to the intravascular space, so the ratio of the hemoglobin to the plasma is the same, and this need usually 24 to 72 hours to shift the plasma volume from the extravascular to intravascular to dilute the hemoglobin and to show the evidence of the drop in the hemoglobin. This is the lesson. So any patient coming with acute upper GI bleeding, even if you look at the hemoglobin and the hematocrit normal, it doesn't rule out significant GI bleeding. This takes usually 24 or 48 hours to show the effect of the drop in the hemoglobin. So this is the most important slide in my presentation, how to manage the patient in the emergency room. The most important after taking a brief history, doing your examination, is to closely monitor the patient. It's very important for airway, breathing, circulation, putting the patient on cardiac monitor, checking the urinary output, putting the patient on oxygen, and very important to insert 2 large bore IV cannulas, minimum of 16. 18 is acceptable also. If you cannot really put a peripheral IV line, it's mandatory to put a central line for the patient. Send blood for all the blood tests that we mentioned before. As we mentioned before, gastric lavage or putting an NG tube is controversial. Bolus infusion of the isotonic saline is very, very important. However, if the patient has a cardiac history, you have to be very careful not to overload the patient. And cross-match and transfuse the blood if the hemoglobin is less than 70 grams per liter. However, if the patient had a cardiac history, we prefer to transfuse the patient if it's less than 90 grams per liter. Also look to the platelets. If they are low, less than 20,000, you have to keep it at least 30 or 40,000. And always hold the medications that cause platelet dysfunction, such as aspirin and Plavix. And if the INR and PT is prolonged, transfuse the patient with fresh frozen plasma plus vitamin K and hold the anticoagulant for the patient, for example, taking the enoxaparin or warfarin. Triage the patient, whether you send the patient to the ward or to the ICU based on the risk stratification that we'll discuss in the upcoming slides, and immediate GI consult is indicated. So our management goals will have the following 5. So number 1 is to stabilize the patient in the emergency room, which is the most important step, and the mortality will happen if the patient is not really well resuscitated in the emergency room. Second 2 is to determine the source of the bleeding. Is it upper or lower? And by doing the endoscopy. Number 3 is to stop the acute bleeding, and this is the job of the gastroenterologist. Number 4 is we treat the underlying cause. For example, if there is an ulcer, we have to eradicate it and treat it in the future by checking the Helicobacter or by stopping the non-steroidal anti-inflammatory agents. And to prevent recurrent bleeding by treating the underlying cause, as we mentioned. This is again the graph just briefly to show you how to approach patients with upper GI bleeding, ABCs, IV fluid, oxygenation, sending the stat lab, and doing the ECG and cardiac enzymes in risky patients. And immediate therapy, very, very important to start the patient on proton pump inhibitor, bolus, then infusion. And if you suspect this patient has portohypertensive bleed due to varices or portohypertensive gastropathy, it's very important to start the patient on somatostatin analog, or what you call octreotide, 15 microgram bolus, then 50 microgram infusion per hour, plus giving the patient antibiotics for 5 to 7 days. And after that, you call the gastroenterologist and to book the patient for the upper GI endoscopy once the patient is stabilized. So when do we do usually the upper GI endoscopy? In general, emergency endoscopy, it is to be done within 24 hours from presentation to the emergency room. However, sometimes we have to rush and do it within 12 hours if the patient has really previous history of variceal bleeding, or for example, if the patient presenting with tachycardia, hypotension, bloody emesis, and after resuscitating the patient, and we can manage in the emergency room within 24 hours, it will be preferred over 24 hours. Sometimes the patient present to the emergency room with, for example, melena for like 5 days or 6 days, and patient is very stable. Do we need to do the upper GI endoscopy in the emergency room? The answer probably is not. And these are the indications for you to discharge the patient without doing upper GI endoscopy on site, and you can book the patient to have an upper GI endoscopy within 24 to 48 hours as outpatient. So if you find the patient urea is less than 18 milligram per deciliter, the hemoglobin more than 13 for men and 12 more for women, blood pressure systolic is more than 110, pulse is less than 100, and there is no history of melena, syncope, cardiac failure, or liver disease, you can consider discharging the patient to the emergency room and giving him appointment within 48 hours for upper GI endoscopy. Okay, what about the pre-endoscopic medical therapy? We have to consider a few therapies before we attempt upper GI endoscopy in those patients. We can consider giving, if there is no contraindication, intravenous erythromycin, 250 milligram, 30 minutes before the endoscopy. This should be considered to improve diagnostic yield and to decrease the need for repeated endoscopy, because it is a prokinetic agent and will clean the gastric from any clots and if there is any debris in the gastric mucosa. The second thing is to give the pre-endoscopy the intravenous proton pump inhibitor, as we mentioned before. It's usually omeprazole or pantoprazole, 80 milligram bolus, then 8 milligram per hour. This has been shown to decrease the proportion of the patient who have high risk stigmata by the endoscopy. If the patient has portal hypertension bleed, you think this patient has a variceal bleed, also you have to add antibiotics and somatostatin analog intravenously. Now we'll discuss a very, very important issue, which is the risk assessment stratification, or the RAS. And I put here for you 2 examples. We have 2 patients, and you will think which one is more risky than other. We have a 30-year-old patient presented to the emergency room with 1 episode of hematemesis. He took 10 tablets of ibuprofen for the past 3 days for a dental ache. He has no other medical problems. When he came to emergency room, he was hemodynamically stable, and his hemoglobin in the emergency room was 140, and his baseline is 142 gram per liter. Compare this patient with another patient. We have a 68-year-old patient who's diabetic, hypertensive, had paroxysmal atrial fibrillation, ischemic heart disease, osteoarthritis, and taking all medications listed here: warfarin, carvedilol, PR, diclofenac, and she presented with 1-day history of hematemesis and 3-day history of melena, and her blood pressure in the emergency room was 90/55. Her baseline is around 110/60. Heart rate is 102, and hemoglobin 72, and her baseline is 120. It's very obvious. The second patient is much riskier than the first patient. Has more risk factor, seem to be unstable in the emergency room, and this is why the risk stratification scores have been created. The risk assessment stratification will help you in the following: to identify and consider ICU admission and CCU admission, to consider doing, for example, serial ECGs and cardiac enzymes. The lowering the threshold for you to transfuse, as I mentioned before, usually you transfuse the patient if the hemoglobin is less than 70. However, for patient with high risk assessment, we can consider transfusion of less than 85 or 90. And we can consider also for those patients early endoscopy, for example, within 12 hours rather than 24 hours. So this will tell you also if the patient is risk for getting more blood transfusions, recurrence of the bleeding, need for surgery, as well as mortality. We have many scoring systems for risk assessment, but the commonly used 3. The first one is the Rockwell score, the second one is the Blatchford-Glasgow score, and the third one, which is the easier one, is the AM65, and I have listed for you the parameters for the AM65. This is the Rockwell score. I don't need to go through it, but it has up to 11 points, and it correlates the score here listed from 1 to 8, but it goes up to 11 with rebleeding risk and the mortality risk. So as you can see, if the patient Rockwell is 1, the rebleeding is a 3, and the mortality is 0, compared with score of 8, rebleeding is around 50%, and the mortality around 40%. And this is the Glasgow Blatchford score. I will leave it for the slides. All the calculators are available online and up to date, and you can do them, and it will give you the result and will indicate to you this patient is low risk, moderate risk, or high risk. How to assess if the patient is still having ongoing bleeding? First thing is that if you find the pulse rate and the heart rate is increasing, if you find the GVP or the CVP is dropping, the urine output is dropping. The other thing is the patient is continuously having symptoms like hematemesis or hematochezia. However, melena may last like 3 or 4 days after the bleeding ceased. If the patient has NG tube and continuously irrigation and you find the fresh blood is coming out, this might indicate the patient is still bleeding, and also monitoring the hemoglobin, indicating that if there is a drop in the hemoglobin from day to day, this indicates the patient still have ongoing GI bleeding. Now let's discuss about the role of endoscopy. The role of endoscopy has 3 things. Number 1 is diagnosis, number 2 is the treatment, and number 3 is the prognosis. Let's now think about a patient we have scoped and we find, for example, an ulcer. We'll start from the right side. So if we scope the patient and we find a flat spot or clean-based ulcer, there is usually no need for any endoscopic treatment. And the patient can be given oral proton pump inhibitors and discharged home. Make sure that you think of eradicating Helicobacter pylori and ask the patient to stop aspirin and non-steroidal anti-inflammatory agents. If you find the patient has an adherent clot, it is controversial, but most of the gastroenterologists, they will tend to remove the clot and treat what is the underlying pathology, either by injection plus, for example, putting a hemoclip or thermal coagulation. If the patient has an active bleeding or non-bleeding feasible vessel within the ulcer, endoscopy treatment is mandatory, and usually we give a dual treatment such as clipping and epinephrine injection, or epinephrine injection and thermal coagulation. So peptic ulcer disease, stigmata causing the rebleeding, it depends on what was the pathology seen by the endoscopy. If you find a cleave-based ulcer, the rebleeding risk is very minimal. It's around 5% or even low. If the patient has a flat red spot, it is 10%. If there is an adherent clot, it's around 20%. If there is what we call non-bleeding visible vessel, it is 45%. If there is an ooze, this is 55% rebleeding risk. And if the patient has an active spurting, the rebleeding is around 95 to 100%. If this is, of course, not really managed by endoscopy, if left alone without management. Endoscopic therapy is indicated if the patient have active spurting, oozing, non-bleeding visible vessel, or adherent clot, but it's not indicated if the patient had clean-based ulcer or flat pigmented spot. Repeated endoscopy is only indicated if the patient has shown evidence of continuous GI bleeding. So this slide also will summarize what I've mentioned before. I will not go through it again, but you can read it if the patient has low-risk ulcer versus versus high-risk ulcer, and it depends on what was the pathology seen by the endoscopy and what will be the management. Do we need to discharge the patient? Do we need to admit? Do we need to give just proton pump inhibitor? Or do we need to do an endoscopic therapy? And I will leave this slide for you to go through it. Now the management by endoscopy, as I mentioned before, it is a dual treatment, 2 rather than 1, based on the studies and recommendations. We don't really recommend a single monotherapy, especially with epinephrine alone. We prefer to give 2 treatments at a time. And there is a meta-analysis of 16 studies, 1,673 patients with high-risk peptic ulcer disease. They gave either epinephrine or epinephrine injection around that bleeder, or epinephrine plus endoscopic therapy, and endoscopic therapy either clipping the bleeding or thermal coagulation. And as you can see, the combination therapy, it reduced the bleeding, reduced the surgery, reduced the mortality with a similar complication to the epinephrine injection alone. So now the rule is we should never give just epinephrine injection alone if there is indication for endoscopic therapy. What are the tools or toys that we are using in upper GI bleeder? We can inject, as I mentioned, epinephrine. We can inject saline for tamponading the bleeding, ethanol, sclerosant, fibrin glue, and thrombin. The thermal coagulation, we have either bipolar or heat probe or laser. We have the hemoclip, we have argon plasma coagulation, the band ligation, especially for variceal bleeding, and endoloop sometimes can be used, especially for if there is a bleeding from polyps, and hemospray and endoclot, you can spray the bleeding and it will cease the bleeding. What about after endoscopy? What are the things that we have to do after we managed already by giving the patient pre-endoscopic treatment with proton pump inhibitor, erythromycin, then doing the upper GI endoscopy, and we try as a gastroenterologist to stop the bleeding. Then after that, what we should do? For patients who have high-risk stigmata of ulcers, like spurting, oozing, clot, or non-bleeding visible vessels, they have to be admitted at least for 72 hours and give them proton pump inhibitors during that time. After that, we shift to the oral PPI and discharge the patient home if he is stable. However, if the patient has low-risk stigmata, we can consider really discharging the patient from the emergency room and give them proton pump inhibitor and see the patient on an outpatient basis. Why we are giving a proton pump inhibitor? It is to increase the pH of the stomach. Remember, the pH of the stomach, normally it's between 1.5 to 2.5, and this will this acidity will be associated with decrease the platelet aggregation, will increase the clot lysis, and will enhance fibrinolytic activity. So by increasing the pH of the stomach, the platelet aggregation will be enhanced, and the clot formation will be stabilized, and fibrinolysis will be inhibited. Remember, the proton pump inhibitor, they are not really useful on patients with low-risk stigmata. For example, if the patient has just a clean-based ulcer, we can consider just giving them an oral PPI without need for intravenous PPI. The proton pump inhibitor should be considered as adjuvant for endoscopic therapy. It should not prevent you from doing the endoscopic therapy and treating the ulcer if it's bleeding or oozing. And are all PPI equal in their clinical efficacy? Probably yes. And is it equal between oral versus intravenous? We'll come to that in the next few slides. So this is a slide will show you that stabilizing the pH, keeping it more than 4 and optimally to be more than 6 in the stomach will make actually the fibrinolysis is less compared with patient who has acidic pH. Pantoprazole or omeprazole and esomeprazole usually given intravenous first as a bolus 80 milligram, then 8 milligram per hour, and this is the best to stabilize and keeping the pH in the stomach above 4.5 or 5. This is a landmark study, a single-center, double-blind, placebo, randomized control study giving omeprazole intravenously 8 milligram, then 8 per hour, versus the placebo. They have 240 patients with a bleeding ulcer or non-bleeding visible vessel and given combination of endoscopic therapy, as I mentioned, intravenous omeprazole infusion given for 72 hours after endoscopic therapy versus a placebo, and they looked for the findings. So the outcome is the 30 days bleeding. It was significant on those patients who did not receive the proton pump inhibitor for 72 hours. As you can see, the p-value is less than 0.05. It was 6.7 in the omeprazole group compared with the 22.5 in the placebo group. However, requirement for surgery and mortality rate was better in patients who received the proton pump inhibitor for 72 hours, but it was not statistically significant. Now, PO versus IV PPI can we give? We prefer usually to give intravenous because we make sure that it goes to the systemic circulation, suppress the acidic pH, and the patient usually might have a nausea or vomiting. We have a large clot in the stomach and the bowel to prevent the absorption. However, there is no head-to-head comparison between oral and intravenous PPI, and there is no really single study that showed significant mortality benefit. However, there is a meta-analysis that showed that rebleeding in patients who receive intravenous PPI is less compared with the rebleeding in patient who's receiving oral PPI. However, surgery and mortality, it is not significant. What about the timing for the proton pump inhibitor? Do we need to give it the pre-endoscopy? As I mentioned before, we prefer to give it pre-endoscopy. Why is that? Is to reduce the stigmata of the ulcer. If, for example, the patient has an spurting or oozing blood, and you do the endoscopy with the proton pump inhibitor given before, you might find actually either flat spot or adherent clot because you stabilize the clot and you increase the pH in the stomach. And this is the study showed it was a randomized control, 369 bleeders given IV PPI before the endoscopy versus placebo, and the endoscopist went in, and what did they see? The high-risk stigmata was 17.2 in the patient who received omeprazole pre-endoscopy therapy compared with 35.7% in the patients who did receive only placebo. So intravenous PPI pre-endoscopy fasten the resolution and reduce the need for the endoscopic therapy, but there is no change in the mortality. What to do if the patient rebleed again? There is a study, 92 patients who have high-risk ulcers and recurrent bleeding post-endoscopy. You have two options. Either you go by endoscopy again or you send the patient for the surgeon. As gastroenterologists, we prefer to go and give us another chance to stop the bleeding, and this is the result of that study. The outcome, repeated endoscopy stopped the bleeding in 73%, and the complication compared with the surgery reduced 12.5 in the endoscopy compared with 36 in the surgical, and the mortality was 10% versus 18% in the surgery, which was not significant. Hospitalization, always high-risk patient has to be hospitalized for at least 3 to 4 days, and low-risk patient, they can be discharged from the emergency room and to be followed in the clinic within a few weeks. Now you have managed the ulcer and you stop the bleeding and you discharge the patient. You have to think about the long term, try to prevent the bleeding from happening again. So if the patient has a Helicobacter pylori, it has to be eradicated. If the patient is taking non-steroidal, we try to shift to less toxic or gastric toxic non-steroidal, such as the COX-2 inhibitors, selective inhibitors, such as celecoxib. If the patient is taking aspirin, for secondary prevention for cardiac or stroke, we can discuss with the cardiologist or neurologist if we can shift the aspirin to another agent such as clopidogrel. If the patient is using the aspirin for primary prevention, it is better not to take it, and we advise the patient to ask the cardiologist if there is a need for aspirin or not. If there is a need for aspirin, we usually combine aspirin with the proton pump inhibitor lifelong if the patient experienced a previous history of ulcer bleeding. If the patient has an idiopathic ulcer, they have to be on long-term proton pump inhibitor, at least once daily, 20 milligram breakfast. If the patient had history of portal hypertensive bleed, it is very important to give the patient non-selective beta blockers such as nadolol or propranolol to reduce the portal hypertension. And if there is no contraindication, however, if there is contraindication, for example, the patient has congestive heart failure or bronchial asthma or heart block, we have to consider this patient for repeated endoscopic variceal ligation. For a patient to have one episode of upper GI bleeding due to variceal hemorrhage, the best is to combine non-selective beta blocker and endoscopic variceal ligation until the varice is obliterated. Then you continue the patient on long-term non-selective beta blocker. This slide summarizes the things that you have to think about prior to discharging the patient from the hospital. So if the patient has Helicobacter pylori, eradicate, non-steroidal. If it's not really indicated, you have to stop it or switch, for example, to other agents for like painkiller, such as Tylenol, or less toxic non-steroidal to the stomach, like COX-2 inhibitors. And the low-dose aspirin, if it's for primary prevention, probably the patient will not need it. If it's for secondary prevention, we can combine aspirin with proton pump inhibitor. Otherwise, the patient also can be switched to other antiplatelet agents such as clopidogrel. If the patient has idiopathic ulcer, we have to maintain the patient on long-term proton pump inhibitor. Few slides on variceal bleeding. We have the first one on the left side is the esophageal varices, and the top it is non-bleeding, and the bottom it's bleeding. The second one is the GV or gastric varices, usually in the fundus and the cardia of the stomach, and sometimes in the body and in the antrum. And usually they bleed massively, and they have to be treated with the glue injection rather than the sclerotherapy. And the other pathology is what we call portal hypertensive gastropathy. It is like appearance of severe gastritis due to congestion of the blood vessel in the submucosa, and sometimes causing subacute or chronic blood loss, and sometimes acute upper GI bleeding. What to do for esophageal varices? We have to ban them. The best thing is to ban them. We avoid doing sclerotherapy anymore. If the patient failed banding, we can consider sclerotherapy. For gastric varices, as I mentioned before, we do the glue for that. And if it failed, sometimes we send the patient for TIPS, which is transjugular intrahepatic orthosystemic shunt. Is there any role for angiography? The role for angiography, if we failed to cease and stop the bleeding by the endoscopy, so prior to send the patient for surgery, we might give the radiologist, the interventional radiologist, an attempt to do angiography and to localize where is the bleeding artery and embolize it and clot it with the embolization technique. And unfortunately, this might have some complications listed here, such as ischemia, infarction, perforation, and abscess formation. Again, the surgery, it is the last source. Usually it is reserved for patients who failed the treatment, either portal hypertension, and usually they do devascularization and splenectomy, or for non-portal hypertensive bleed, they do, for example, partial gastrectomy, or sometimes they do the ligation of the gastroduodenal artery. This slide will summarize my talk regarding the upper GI bleeding. Remember, upper GI bleeding is a common medical problem. History is the key in all cases. Resuscitation and stabilization in the emergency room is the most important thing. Risk assessment stratification is very crucial. And pre-endoscopic treatment preparation. You have to give IV erythromycin if no contraindication, start proton pump inhibitor intravenously. If the patient has stigmata of chronic liver disease, give antibiotics and somatostatin analog. Send the patient, very important to, first of all, to cross-match and insert IV cannulas and resuscitate the patient, then call the gastroenterologist for upper GI endoscopy and treat the underlying cause, either it is portal hypertension or non-portal hypertension. Before I conclude, I will recommend for everyone to read the American College of Gastroenterology guidelines that was published in 2012. It is very thorough and detailed guidelines, and there are a summary for that. So I recommend it for everyone to read about this to illuminate more about upper GI bleeding. We have many references, but I took most of my presentation from the up-to-date 2015 and Schlesinger and Fortran, the 10th edition. Thank you so much.